All right, welcome back. This is part 3 of Hope Corps' core concepts in global health. We'll re-begin where we left off, which is community-based delivery systems and their relationship to to accomplishing good healthcare numbers in the developing world. And as we said before, in 30 years of consulting in the developing world, I can say that no project will be sustainable unless it is significantly community-based. Unless the community takes ownership in what's going on, no matter how much money is poured in, eventually those programs will atrophy and disappear. In our case, we have incredibly good relationships with the Ministry of Education and also the Ministry of Health. We have won multiple awards from the school system as being the nonprofit that has offered them the most benefit over the years. And in another video, I will actually look at a recent communication we got from the Ministry of Health, which documents, number one, how happy they are with our services, but number two, that they have seen decreased absenteeism in the schools where we have our medical clinics functioning. We have memorandums of understanding with both the Ministry of Health and the Ministry of Education. We also work closely with the local hospital. So community-based then becomes extremely important if you're going to be able to sustain your program, and you can never scale up a program unless it's sustainable. So if you first get it to the point where it is community-based and sustainable, then you can move to scalability. So we're going to look at curative services, prevention modalities in health education. And really, we put health education at the top because the two bottom things, good prevention modalities like clean treated drinking water in the schools, hand washing, and bed nets, all depend on particularly the mothers, at least for the young children, knowing that these are important interventions in the health, in the protection of the health of their child. So we're one of the small nonprofits that has done maybe the most, definitely the most in our area on prevention modalities. At this time, we've placed over 20,000 of the 5-year new insecticide-treated bed nets into the community. No other nonprofit in our area has accomplished that. That's been done over the period of about 4 years. And we are now focusing heavily on getting all of our entering classes in our elementary schools, these would be the 5 or 6-year-olds, to have nets in the home. We bring the parents in for malaria education so that they understand the importance of placing their children under nets. And then we actually go into the homes and monitor that the nets are actually hanging, that they're being used and used properly. We also made history in Kenya for being the only school system, and in our case with about 45,000 to 50,000 students, who has clean, treated drinking water systems in all 200 schools, which Hope Corps put into those schools. We've also pioneered putting in hand washing stations with soap in those same schools. And we will look at these programs individually in future videos. But the importance here is to really emphasize that Hope Corps really does walk its talk as far as prevention goes. We have been a model in our area for doing that. And in 30 years of consulting, there is frequently a lot of talk about prevention, but frequently little is done, as is the case in health education. Most of the things that people do are focusing on curative services, will certainly have their place. And in the next video, we're going to go into detail about the relationship of curative services versus public health services in developing world communities. So we will get back to that. But certainly health education and prevention go hand in hand. And we have been the leaders in both of those in our particular area. Now, I want to hit hard, and I may have mentioned this before about prevention. People really don't understand how cost effective prevention is. And as a physician who spent 23 years of his life doing clinical medicine in Northern California and also in the developing world, let me give you an example of the type of things I've seen. So you'll see a child that we'll see in one of our school mobile health clinics who comes in with classic symptoms and signs of malaria, is treated with an artemisinin combination medication for possibly about a cost of $1. Now you take that same child and instead of treating them right away or bringing them to a place that didn't have any medicines or treated the child with the wrong medicine, and now the child returns 3 to 4 days later, but this time that child returns in a coma because that child now has advanced falciparum cerebral malaria. And that child will then end up in the hospital, may spend a week in the ICU, may be longer, may not survive at all. And if the child survives, literally thousands of dollars and thousands of dollars worth of resources can be spent on a child where this could be prevented with $1 worth of medicine. The same with immunizations. So if you're going to, as we talked about before, if there's 2.5 billion critically poor people on the planet, then it's absolutely critical that our services be medically effective, but also cost effective. And prevention is certainly the key for cost effectiveness. You will never get any medical therapies or curative services that are going to be cheaper than good prevention. That's extremely important, and it's one of the principles that our program is built upon. So if we're going to do prevention, then the question is, what is the best way to do prevention and what is the cheapest way? Because again, we're looking at potentially hundreds of millions of people here. And so, you know, what we talk about in our program is go where the money is. And the idea here is that if we're going to do prevention, as you're going to see later, the areas where we want to focus our preventive activities are on mothers and children, and we'll go into that in detail further on. Then we need to go where the mothers and children are. Well, when we started this program, we really began with our microenterprise clients, and we weren't working yet in the schools. And every day we'd send out our nurse, a driver, a four-wheel drive vehicle, and we'd go and visit the individual homes of these people. When we looked at that over a period of 4 to 5 months, we realized how inefficient and expensive that is. Number one, because of the topography, which you're going to see in a later video of where we are on the slopes of Mount Kenya with all these difficult four-wheel drive roads, we can only get to maybe 7 or 8 families a day, and which is very expensive, and that frequently the children who we wanted to see weren't in the home. They would be either in school or out playing or elsewhere. So it was an extremely inefficient way to go, and we saw this 5 or 6 years ago, and that's where we moved to moving into the schools. So basically, if you look at our area, where do people congregate? By far and away, the most important is the schools. There are 200 schools in these 516 villages, and all the schools are about less than an hour walking distance from a family's home. So the school tends to be the center of social interaction. The mothers will bring their younger children to school. The school is very well known in the area, and it's an easy place for the mothers to access, and of course the children have to be there anyway. So basically, if you go to the schools, you get the children, and as you're going to see, when we talk about the exact programs we do, we have our school mobile health clinic in the mornings where we go to the schools. The schools allow us to use their facilities. We set up curative services. At the same time, we run educational health lectures for age appropriately for the children, whether it be in elementary schools or secondary schools. And we actually bring, since our schools do not have electricity, we actually bring a generator, a laptop, an LCD projector, and a screen, and we do age appropriate PowerPoint presentations for young children, for middle-aged children, and for secondary children. So the schools then become the #1 area where people meet. The second area that they meet is obviously in their neighborhoods. So people live on their small farms of 1 to 2 acres, which we're going to see in a future video. And basically they interact a lot with their neighbors because many of their neighbors are actually extended family members. They're all of the same tribal group, which is the Wameru group of Kenya. And even if they're not related, they frequently are intimately involved with the other households in their area, in the sense that they will help each other when they have to work. They will be socially connected, and so the neighborhoods then become, after the schools, the second most important place where people meet. And then the third certainly is the market days. This is still rural Africa, where markets move, these traveling markets. At one particular day, they will be in one area, another day of the week, another area, and they will move around. And that's where people will frequently go and meet. And that's certainly an important place for us to be. And we do have a strong market day program, as well as a neighborhood clinic program, which we'll talk about again in the future. And the fourth, and it is churches, and that people do. The Kenyans are very religious. They do go to church on Sunday. It is very important in their community to do that. And we have partnered with a number of the churches to be sure that we can use their services and give health education to their congregation. So that's also very important. So going where the money goes really simply means that we are not going to be in a clinic. We are not going to be in a private office. We're not going to be in a hospital. We're going to take all of our services and go to where the people are, go where the money is. And that's where the mothers and children are. That's where we want to do our prevention. Another thing people don't realize is that's extremely cost effective. We don't build any hospitals. We don't build any clinics. We actually use the facilities when in the school system. So there isn't any brick and mortar cost. We rent offices. We obviously have an office, and we have a small one-room clinic where we will refer sick children back to us. But basically we have no brick and mortar costs. Our rents are low. And we do all our work in the field, whether it be in the neighborhoods, the schools, and also teaching in the market days and in the churches. So a very important principle of doing public health in the developing world is not attempting to do it from clinics or hospitals, but going to where the people are. You know, in 30 years of looking at clinics and working in hospitals in the developing world, I can tell you how underutilized they usually are, and that when people go to those clinics, it's never for prevention. They always have a significant, usually medical problem, because first of all, they're worried. They're worried about the health of themselves or their loved ones, and they're also worried about the cost of what this will do to them financially. So they tend only to come to clinics and hospitals when they're very ill. And this is very similar to what I saw in the United States. Despite the fact that we are a developed world country, most of the people coming in and seeing us come when they actually have an acute clinical problem. So, as we've talked about, we are heavily school-based. We run our school children program in the morning, whether it be an elementary school or secondary school, where we do our health-based education and curative services. And again, we'll talk about that in detail. And then in that same school in the afternoon, the schools have allowed us to use their facilities to educate and to treat all the mothers that are in that particular school's catchment area and their preschool children. So this is where in the afternoons we see the mothers and the preschool children. All those preschool children will eventually go to this school. And in the morning we will see and educate and do preventative services for the actual school children. We will go to the market days where we have basically a boombox and a tent. We do HIV testing. We do blood pressure testing. We talk about our health hotline, which again, we'll talk about in another video. That's a very important way to make our presence known in the community. And we are in all the major market days in this particular area. We also attend community events when they occur. These would be things like Hand Washing Day, World's Malaria Day, celebrate the African Mother and Child Day, different events that occur. We are always in evidence and usually work with the Department of Health in those areas. We are also have a program that has just been funded and is just starting, which is going to be very important. It's our neighborhood clinic program. And what that is basically is the celebration of the African mother and child, or the Kenyan mother and child. And we will discuss that also in detail in the future. But basically what it is, if you at least come from the United States, it is like a health Tupperware party. Basically, we go to a woman who has been part, that we know has worked with us or has been part of our microenterprise bank, and we basically rent her facilities in Goodwill for an afternoon. We ask her then that we can come to her compound and bring our team, our nurses to do curative services, our educators to do education, and we then ask her to invite all her extended family and all the community members that live in her neighborhood and around her area. And we have our community health workers go out to try to bring people in. This has been very, very successful, and this is going to be a major program that we are going to be putting out at full scale in the next 2 to 3 months. And we will have a complete presentation on this Celebrate the African Mother and Child. So what we're going to do is we are going to look, or what we have done is look very closely at what are the drivers of good health indices in the developing world, the drivers of good life expectancies, the drivers of low infant mortality, the drivers of high under 5 child survival. What are the things that really drive those numbers? And personally, in my own research, I've done a lot of work looking into those. And we will do a number of presentations on that particular concept. But for the moment, if we cut to the chase, what basically there is good evidence to show is that in the developing world, there are certain what I'm going to call child survival technologies. These certainly affect the child, and some of them also affect the health of the mothers. And these are extremely effective, medically effective. Compared to other medical services, they're extremely cheap, and they're certainly available to us to be brought into the developing world. These are things like vaccines, simple antibiotics, oral rehydration therapy, protein supplementation in children, the growth monitoring of children, child spacing to protect the child and the mother, good prenatal care and perinatal care and education, treated bed nets in our area for malaria, along with clean water and soap for better hygiene, the emphasis on breastfeeding, and of course, the emphasis on family planning, allowing a woman to control her own fertility. Getting back again to these 2050 and the fact that 39% of the children in the world will be in Kenya, and will be in Africa, and that we're basically going to have to supply services for those children, those families. So we never want to do just mortality reduction interventions, because that will only throw kerosene onto this particular problem. What we really need to do is combine mortality reduction interventions with fertility reduction modalities, and that's why family planning then becomes so incredibly important. So let's pause here. This is a good break point. The next video is probably maybe the most important of all in the first 10 videos. And we will look at this particular child, we'll talk about her, and we will look at the medical issues that arise in a child like that, and what causes a child in the developing world that is part of the critically poor of the world to really fail. So let's take our pause here.